And now we are moving ahead with the schedule. And our next presentation will be coronary artery stenting in subtotal carotid stenosis. Dr. Stoikova, please.
Good afternoon. Thank you for the opportunity to present you our experience with stenting subtotal carotid stenosis. It's known that arterial hypertension and vascular stenosis may lead to series of changes of the brain, of blood-brain barrier, cerebrovascular dysfunction as a result, and of course stroke. We also know that if no stroke, atherosclerosis can lead to progressively development of cognition deficiency and dementia. Main mechanism of critical stenosis and cognition interaction, we know flow-limiting stenosis can lead to metabolic changes in the brain and also microembolization from the atherosclerotic material. Also, carotid stiffness can lead to increased elevated pulse wave velocities. There are a series of reviews and studies in the literature about the safety of intervention of critical carotid stenosis. This is one study versus which evaluates critical versus high-grade stenosis lesions intervened with CAS or enderectomy, and the study found that results are almost equal in both groups. Another review of intervention of near occlusion that has similar results, and another 30-day and long-term outcome review on those patients. CREST, we know, CREST 1, CREST 2, we learned from them that those patients, their upper percentiles of distribution of cognition score are pretty lower than general populations. And we also have positive correlation between change of perfusion of the brain and changes in cognition tests. Also, we see in compared to medical therapy in CREST-2 versus stenting or enderectomy, we have better results, especially in the carotid artery stenting group. Our experience, we are single center. Our patients were evaluated from 2020 to 2026. During that period, we did 864 carotid interventions, but in 302 lesions, they were severe, above 95%, and 203 stenosis were above 98%, or we consider those string sign lesions. Those are the exact numbers of interventions done through the years. During the period 2021 to 23, we have averaged 60 patients per year. The gender, predominantly we have male of 202 patients, average age is 67, arterial hypertension, I'm speaking about previously treated one, we have in 110 patients, previous stroke in 15% or 46 patients, and previous carotid intervention in 17 patients, or 5.6%. The stenosis, the second graph shows that in 33% of our population we had stenosis above 98 degrees or string sign. And the RIC localization was almost equal. Mainly the pathology was stenosis. We had several patients with restenosis, some with stroke, and I think one patient was with aortic dissection that propagates to the carotid artery and caused severe stenosis. The access site in almost equally we have femoral and right arm approach. Right arm, it combines brachial and radial approach. And in 3 patients we needed to switch our access sites due to inability to place the sheet. Also in 21 patients we managed to do the intervention with a deep loop. We very much know that atherosclerosis may also involve coronary arteries, so we did coronary angio in 184 patients, and we found significant lesions in 164 of them. And in 9 patients, we performed PCI on the same procedure as carotid intervention. Predilation we did in 59% of our population, but in 90% we couldn't place distal protection without predilation with 1.5 balloon. We used mainly one stent in several patients. We needed to use 2. I think maybe in one patient there were used 3 stents, and there the lesion involved also the common carotid artery. The main type was exact stent, several wall stents, protege, the others not so many. Balloon post-dilatation we did in 86%, and about the lesion characteristics, we had thrombus and unstable lesion in 7 patients with calcium, I mean severe calcic stenosis, in 50 patients. Average proximal diameter of the stent was 8 millimeters and average distal 7 millimeters, average length 34 millimeters. Success rate was 98%. We had 2 complications. One stent got detached and we needed to implant it in the brachial artery. One LECA got occluded, totally occluded. We had also 4 procedural failures, 2 uncrossable with balloon and 2 uncrossable with wire. A few words about thermography, which we use in our center. We know it's a safe tool used previously, and there are a lot of publications about its safety and its ability to validate lower temperature in severely ischemic zone. We may use it as quick and reliable, non-operator dependent tool to evaluate patients. This is a case with a 68-year-old male with recent TIA with speech disorder, and this is the thermogram before the procedure. This is the angio of the carotid artery, the left carotid artery with slow flow distally. This is the angio after stent placement, of course, distal protection, predilation, and the final angio distally. This is the thermography after the procedure was done. You can see that there was no zone difference, temperature difference between the zones. Before, after, for comparison and take-home messages, a safe method that can be radiation-free and time-saving. There is a trial in our clinic, the string trial, that we know better that patients for intervention need better selection. We so far included 78 patients, 39 with having dynamically significant carotid stenosis and 39 controls. And we do cognition testing and biochemical testing before and after the procedure, and also we do a perfusion MRI. And this is one patient with hypoperfusion and before carotid stenting. This is the intervention, the cognition test that was done. I'm sorry, not here it is, the actual angio with severe calcium stenosis of the carotid artery, and this is the intervention itself. Crossing, sorry. The final result. I hope it goes distally. And here I wanted to show, I think the third slide. Okay, no, doesn't matter. And this is the final perfusion and CT angio after carotid artery stenting. And we know better that brain perfusion benefit from recanalization, and that acetazolamide reaction was far better after intervention. Future directions. We have a lot of questions to clear: biochemical biomarkers, microcirculatory reserve, cognitive decline, and function. Thank you very much.
Thank you for your speech. I'm sorry, maybe I misunderstood, but as far as I read the results from CREST-2, the main, the conclusion was that there was no impact to the cognitive deficit. Actually, they told that revascularization versus medical therapy, we have no difference.
In fact, that is the point of our study, to evaluate cognitive deficit before and after, and if string in those severely stenosed carotid arteries can benefit cognitive function. So far, unfortunately, we don't have significant, statistically significance about cognitive dysfunction. But we hope we have too little cohort of patients. Our patients are only 39 so far. We are developing and continuing our long term. Some patients have really good results after stenting. It has happened, in fact. And the others, they just keep their basic first-line level, but why not try? I mean, even for a patient, if...
I definitely am not against it. I just say that in the big trial, there is no firm proof that we have improving the cognition. And then you have a big basket to the patient with severe stenosis, but still antegrade flow, and some patient with some flow, but which didn't reach the cranium, and it's probably different animals. I'm not sure that it's the same kind of patient.
We actually measure gradient to the carotid artery. We use DPR and measure before pressure gradient. That is the thing we can do during our trial and our procedure, with the idea to prove and to evaluate also the result from gradient coping on cognition and on perfusion and all. About CREST, that table, that figure that I showed, it meant that the majority of patients with severe carotid stenosis, they had cognitive impairment, but whether it goes well, we want to prove with we want to study.
Okay. Other questions? No? Thank you. Thank you so
Thank you.
much.